Good morning. Thank you for having me. It's always fun to be here. I learn a lot from you, the consumers, as much as I hope I can share what we do. This year I was asked to speak about lipid emulsions, only because now we have choice in the marketplace, something we haven't had for decades. I'm a bot woman. I do get research support from various organizations, so there are my disclosures. We're going to talk briefly about how these products came to the market. We're going to talk about what the data was, that wasn't me, what was used to approve the products, just so you could appreciate what I tell you, why we don't have Toro lock in the US, when I tell you why lipid emulsions were a problem, bringing those in, and what the differences are in all the new products that we now have in the marketplace. Just for a little trivia, lipid emulsions are not new. We've been trying to get this right now for centuries. In the 17th century, there was this physician, Dr. Corton, who gave straight olive oil to dogs. Dogs didn't do well. They all got embolism, they died, because it was straight olive oil. And during a cholera epidemic in Canada, this other, Edward Hodder, gave milk IV to people. Miraculously, they survived. That was before we had germ theory, so who knows what was going on. Nobody else could reproduce the results. And then after World War I, that's when we started to see some improved technologies. War is actually very good for IV therapy. A lot of the improvements we saw were the result of war. IV catheters came out of World War I. So sometimes war could be good. But Japan and the US were in the great race to develop lipid emulsions from 1920 to 1960. And in fact, if you look at the data back then, they didn't call it lipid emulsions, they called it artificial chylomicrons. So if you look in the old references, that's the search term people would look up. You wouldn't look for fat emulsion or anything like that. And because we learned that dogs died when you gave IV oil without any emulsification, they had to come up with a safe emulsifying agent in order to get that oil into the water so they could give it intravenously. If you're a chef or you know how to make mayonnaise, that's what you're doing. An IV lipid emulsion is like making mayonnaise. It's an oil and water emulsion, and it's not as easy as you think to make it. It's kind of an art. That's why there's not much out there. And in fact, we've got a product in the 1950s, early 60s called Lipomol that the US had. It was made by Upjohn, and it was made with cottonseed oil. And it was emulsified with soy phospholipid and polaxamer. That's actually what makes ice cream smooth. Unfortunately, they didn't get it right. A lot of side effects, and as a result, patients got sick, they died, and it was pulled off the market by the FDA. So the FDA didn't like lipid emulsions. In fact, they had no interest in bringing a product to market. So that left only dextrose as our calorie source for IV therapy. So over in Sweden, Dr. Arvid Wretlind is actually the man that brought the field forward. He's considered the father of complete nutrition. He's the gentleman you see with Dr. Dudrick. In 1961, he came up with the egg yolk phospholipid emulsifier that we use in all lipid products today. So he made it a safe emulsion. So what's common to all these products? Well, all these products have water for injection in it. As I mentioned before, it's an oil and water emulsion. So the majority of these products are simply sterile water. There's the egg yolk phospholipid emulsifying agent that keeps the oil in the water phase. That's what Dr. Wretlind developed. There's no egg-free lipid emulsion anywhere in the world. They also have glycerin in there to make it isotonic, to keep it stable, as a stabilizer. And it also has sodium hydroxide to keep the pH high. Fat emulsions typically have a pH of around 9. By the time they're expired, they go down to 6. Now, for anybody who has a child who gets a TPN, they have a lot of calcium phos in those solutions. They need a pH that's low, so it's kind of which is more important. With the lipids versus calcium phos, it makes it a challenge because dextrose protein tends to be acidic. So it's like putting lemon juice and tea with milk. It might curdle if you don't do it right. So what's different? What makes these products different? Well, we'll talk about these differences, but it's the phytosterol content, how much vitamin E is present in the emulsion, as well as what's the inflammatory characteristic of that oil source itself. And none of this stuff is on the product label. So you have to be a geek and want to go into the references to look at it, or find somebody like me who's a geek who read the references. Phytosterols are actually plant sterols. They look like cholesterol. And when you take it by mouth, very little gets absorbed. However, when we grind up like a soybean to make it an intralipid, and to give it a lipid emulsion, you give it IV, you bypass your stomach and your GI tract. And when that happens, you get all that phytosterol in your bloodstream. And that's been shown to decrease bile flow. So you can get stasis, it might contribute to liver dysfunction. And when you look at the different products, so let's see if I got the pointer here. Yeah. The different products, you do see a difference in the amount of phytosterols. Intralipid, being pure soybean oil, has the most phytosterols because it's all plant. Now to compare that to fish oil or Omegaven, there's very little phytosterols, and that's because the only phytosterols you see in Omegaven is what the fish ate. Fish, without it, don't. The next one, vitamin E, is in the form of alpha-tocopherol, and it's added to oils as an antioxidant. It's been shown to prevent hepatic injury. In fact, before the Europeans had choice in their lipid emulsions, there was a physician, Olivier Goulet, who routinely added vitamin E to his Intralipid to prevent liver disease. But now he has different options available. But it's been shown that if you take prolonged infusion for courses of therapy of pure soybean oil, you may deplete your natural cell membranes of alpha-tocopherol. And in fact, if you look at soybean oil, it's in the form of, what's present in soybean oil is gamma-tocopherol, which is less bioactive than alpha-tocopherol. And when you look at the different lipid emulsions, you also see that they're different in vitamin E content. Intralipid, as I already mentioned, has very little vitamin E. Omegaven and SMOF, because they both have fish oil, both have more vitamin E because when the refinery that makes the oil for those products, they have to put it in at the time of processing. Why is this jumping? I didn't touch it. I don't know how to go back. I'm sorry. Okay. It goes back. Let's see. They have more vitamin E just because they have to at the time it's processed because it will get rancid. So you can't have a fish oil emulsion without vitamin E because they have to make it at the fish refinery when they process the oil so it doesn't go bad. So let's talk about the specific oil sources. Soybean oil is the first one that did come to market in Sweden in the 1960s. It's a blend of omega-6, which are pro-inflammatory fatty acids that are actually metabolized to arachidonic acid, has a little bit of oleic acid, which is omega-9, has a little bit of omega-3 fatty acids. Very low naturally in vitamin E, and has a lot of phytosterols because it's all plant. The dosing is fairly been well described. You only need 8 to 10% of your total calories as soybean oil to prevent essential fatty acid deficiency. So that makes it okay to do the lipid restriction approach where they do the gram per kilo per day to prevent liver dysfunction because it has sufficient essential fatty acids in the product. The other oil source, the M in SMOF, the MCT oil, is a medium chain triglyceride. It's either from coconut oil or it comes from palm seed oil. It has caprylic and capric acids, and it acts more like a sugar than a fat because it's readily oxidizable, so you can get some fast energy. It's considered neutral inflammatory characteristics. There's nothing there. It's just calories. So it may be protein sparing. It doesn't have any hepatotoxic properties, doesn't affect your immune function. So it sounds really good, doesn't it? And it's resistant to peroxidation. It actually makes more stable 3-in-1s because it doesn't impact the emulsifying agents. So it's actually a very good oil source for a total nutrient admixture where the lipids are mixed in with the dextrose and protein. The problem with this is no essential fatty acids. You will never see an MCT oil emulsion by itself. It has to be mixed with an oil source that has essential fatty acids like soybean oil or other oil sources. Olive oil has also been around since the 1990s. They've been using it in Europe and Asia since then. It's a blend of 5% linoleic acid. Soybean oil in comparison is 50% linoleic acid, the omega-6 fatty acid. So it's usually mixed with another oil source because it's fairly low in essential fatty acids. It's considered a neutral oil in regards to inflammatory characteristics. It naturally has less phytosterols in comparison to soybean oil, has naturally more vitamin E in its formulation. It's fairly stable. So I mean, it's a fairly decent oil source, but it has to be combined with another. And the last, the F, is the fish oil. That's the opposite of soybean oil. It's mostly omega-3 fatty acids in the form of DHA and EPA. You probably have heard about that in baby formula. We use it for heart health. Has some arachidonic acid, which is an omega-6 fatty acid, so it does have all the essential fatty acids in its formulation. Because it's fish and not plant, there's very little phytosterols. The only phytosterols are what the fish ate. Very rich in vitamin E because it has to have vitamin E because of what happens at the refinery. And we know it for both nutritional benefits as well as therapeutic. In fact, we've FDA approved oral fish oil to treat hypertriglyceridemia. So there is some therapeutic benefit to it. So in summary, the function of all these different oils is on this slide. The soybean oil is simply a source of essential fatty acids. The MCT oil also allows you to decrease other oil sources and give calories. The olive oil has less anti-inflammatory, less pro-inflammatory properties. It also allows you to give less soybean oil. And the fish oil also has immunomodulating functions. So again, they all have a little bit different, but they're all a source of calories. That's the thing you have to remember. They all have calories, and with the exception of MCT oil, they have some essential fatty acids. So why do we want to reduce the soybean oil in what we take when we give IV therapy? Well, again, we've learned over time that too much omega-6 fatty acids, too much of the pro-inflammatory fatty acids may not be good in many different patient populations, so we want to decrease it in our diet. And there's two ways you can go about it. One is to simply reduce the dose, or to mix it or dilute it down with another oil source that either has neutral inflammatory characteristics or different inflammatory characteristics. So that's why you're starting to see these mixed oil emulsions appear in the marketplace. The favorable balance between omega-6 and omega-3 fatty acids is theoretically 2.5 to 1 if you into the paleo diet. Intralipid, in comparison, has 7 parts of omega-6 fatty acids to 1. And if you look at a McDonald's diet, our lovely American diet, that's 16 to 1 omega-6 fatty acids to 1, very unhealthy. Back before the industrial age, we were down like to 2 to 1, so over time our diets have gotten progressively worse. And again, the emulsions are all enriched with alpha-tocopherol to maintain adequate antioxidant statics, so you don't get that peroxidation of the fats. So this is just summarizing all the different products that we currently have seen around in the U.S. And you can see that, like, soybean oil has mostly linoleic and alpha-linolenic omega-6 and omega-3, have to metabolize it down to these. The other two, Omegaven and SMOF, have less of those oil fatty acid products, but they have the downstream metabolites. So I mean, they do have different ratios, so they are different that way. However, how do we get these products in the U.S.? This is something you might be intrigued at because everybody asks me always the question, why aren't certain products still not here? Well, Intralipid, again, was approved in Sweden in 1962, developed by Vitrum, which was a Swedish family company, eventually acquired by Kabi. And in Europe, they've started to see a lot of generics come on the scene. However, because of the bad experience the U.S. had with Lipomol, didn't come over here. Dr. Dudrick actually had to do a lot of IV dextrose. They called his method the dextrose system. And when he had to provide essential fatty acids, he had to give the parents of the baby that was in that first case report a high-fat diet and give blood transfusions in order to give that baby essential fatty acids. That's how ingenious he was. He improvised, and that because he didn't have access to these products. So we gave them what they needed in the form of a blood transfusion. That's very clever. So the challenges in developing these products was simply, first off, to recognize the FDA viewed it as nutrition, as a source of calories and essential fatty acids. So you're not going to see an American study out there that's going to show you therapeutic benefits. It's very different than what happened in Europe and Asia. So the original products were all approved simply to provide calories, essential fatty acids, and make sure they're safe, because don't forget, we were comparing our experience to that lipomol disaster. No product to date has been approved in the US on a therapeutic benefit. Everything is strictly nutrition. And in fact, when you look at the safety profile, they looked at triglyceride clearance. They didn't look at other outcomes. They were looking at serum triglycerides to make sure the patients could clear their triglyceride levels. Intralipid, like I said, it was approved in Sweden in 1962. Didn't get approved in the US till 1975. And different concentrations were approved thereafter. When the FDA did approve the 20% application, they did ask for some data from the US. They took the Kabi Vitrum data that they had in Sweden, but then they repeated some stuff with using the US Army. They looked at 47 patients. They only gave it from 6 to 21 days. How many of you have been on a fat emulsion for decades? This is how it got approved. 6 days to 21 days. And then they looked at the Swedish data. And that's how it got approved. In kids, they only looked at kids less than 4, nobody older than 4. And it got approved. Liposyn came on the scene. It was made by Abbott. A couple of years later, they had 3 different products. One was pure safflower oil, Liposyn Original. Then they had Liposyn 2, then Liposyn 3, which is all soybean oil. None of which you can buy anymore, but these are the 3 products. When Liposyn was approved, they actually looked at, again, essential fatty acid deficiency. They only used the trine to tetrine ratio. That's the ratio of omega-9 fatty acids to omega-6. No mention of omega-3 status. They looked at patients up to a month. Again, many of you have been on fat emulsions for decades, but they only looked at a month's worth of data. And in kids, they only looked at 5 patients who were on it for about a month. What happened, though, they noticed with Liposyn being the pure safflower oil, because it had so little omega-3 fatty acid, there were neurologic side effects that were discovered in case reports, and they did pull their product from the scene. And then later on, there was a safflower situation, so nobody wanted to sell them safflower to make the oil, to make the Liposyn 2. So again, eventually, there was no safflower oil lipid emulsions. Again, when Liposyn 2 went through their approval, they also looked at growth, calories, and they only studied it for 2 weeks. That's it. Not much more. And again, they did 43 children. That's it. And when Liposyn 2 and Liposyn 3 came on the scene, Liposyn 2 was that 50-50 blend of soybean safflower oil. They just looked at triglyceride levels, and it was approved based on the original Liposyn approval data. And Liposyn 3, which is 100% soybean oil, just like Intralipid, they didn't have any clinical studies done. They just approved based on the 10 and 20, based on previous data. And when the 30% was approved, they had 2 uncontrolled studies, so they didn't compare it to anything. They just looked at safety. And we had a drug shortage not too long ago, and there's a product by Braun called Nutrilipid that was around in 1993, 10 and 20%, that they pulled off the market. I don't know why. I think it was probably for lack of sales. But because of the shortage, they were allowed to bring it back in. And it was approved simply being clinically non-inferior to Liposyn 3 and Intralipid. No claims. It's supposed to be considered equal. It's considered non-inferior. It wasn't worse, but it wasn't better. It was the same. And the way they figure a lot of this out is looking at the USP standards, and that's how you decide if the lipid emulsion's unstable. Is it a risk of causing an embolism if the particle sizes get too large and get trapped in your lungs? And the 2 things they have to look at are PFAT5 and mean particle sizes. And there's certain criteria. All the products in the US currently meet that standard, but it's a challenge, and it's part of the reason why it's so hard to make them. I mean, I make them in the lab now, and it's a challenge to make sure you get the particle sizes just right. And if you don't do it wrong, you can't infuse it. So the new lipid emulsions in the US, what's different now in the approval process? Again, the FDA is still looking at the nutritional non-inferiority studies. They're looking for, make sure the patients still gain weight, they maintain their weight, that they don't get essential fatty acid deficient, they have normal triglyceride levels. So that hasn't changed. However, the FDA now is adding additional post-marketing studies if they deem them absolutely necessary. So now they're looking at phytosterol levels. They didn't care about phytosterol levels in the past. Now they do. They're looking at the PFAT5, that USP Pharmacopeial Specification, when the packaging sizes, design changes. For example, going from a glass bottle to a plastic bag, that makes the lipid emulsion pretty temperamental. And it's a challenge for the manufacturer to make sure it still complies. And sometimes it didn't, and they had to reformulate their products. And then pediatric specific studies. Right now, the new products are not approved for kids. So what has been approved since the 1990s? Well, there was a product approved in 2013 called Clinolipid. If you're from Canada or elsewhere, they call it Clinolaic. That was the first product to be approved in the US since the 90s. It's 80% olive oil, 20% soybean oil. Because olive oil has so little of the omega-6 fatty acid, you have to mix it. It was approved strictly as being non-inferior to Intralipid. No therapeutic claims, no superiority. It was brought in to help with the lipid shortage because there was a shortage of fat emulsions around that time. So they brought it in that way. It actually has a black box warning on it in regards to premature infants. I only mention that because every single lipid emulsion that's been approved in the US has that black box warning. So people should not be alarmed when they see it. It's just put there that babies are at risk for essential fatty acid deficiency. So, so if you see it, you look at all the, nobody reads package inserts for old drugs, but it's on all of them. The way they brought it in as 1 liter bags, and I don't understand that. It had to be filtered, but now we know all lipid emulsions should be filtered. If you look at the new guidelines, you probably are all using a filter on your sets now. But unfortunately, for reasons I don't know to this day, it never became available in the US. They got it approved, but they never sold it. Now, SMOF came out a year ago around this time, but it's been in Europe since 2000. It's not new. It's new to us, but not new to Europe. It's a blend. It's a blend of soy, MCT, olive, and fish oil. I saw the launch at FASPEN. I think it was in Glasgow back then, and or Lisbon, one of the FASPEN meetings. It was based on the Mediterranean diet. The way it was marketed was it's the Mediterranean diet, it's perfect balance. And that's how it wasn't made on therapeutic claims at all. It was just a matter of balance. It has all the anti-inflammatory aspects, the immunoprotection, the pro-oxidant properties. So they figured it might be better in critically ill patients who don't need all that pro-inflammatory omega-6. But again, in Europe and Asia, they can make different claims than we can make in the US market. So you might, if you look at European literature, you're going to see that they use it in a different way that we may use it in the US or the way it's sold in the US. And when they also looked at it, they looked at the fatty acid profiles of SMOF to like breast milk. So in Europe and Asia, they use it in children because it has similar fatty acid profiles as a breastfed baby. So in that situation, if you look at the European literature, you'd feel comfortable using it in children because of this literature that they have. The current approval is only for the adult population. Again, as a source of calories and essential fatty acids, nothing else. No special patient populations or anything. It's just approved on that, non-inferior to Intralipid. Pediatric indication, currently not FDA approved for pediatric patients. That being said, 80% of the meds I dispense at Boston Children's are not FDA approved for kids. And I know for a fact many of the kids in this room are getting SMOF today. So I mean, that doesn't stop you. It's just that the manufacturer cannot market it that way. They can't put pediatric dosing in the package insert. They can't put promotional literature out there saying what pediatric information's there. You'd have to go to a special kind of a sales rep called a medical science liaison, or you go to have the pharmacists or the physicians go to the primary literature to learn more about it. So it makes it a little more difficult for people who are trying to treat kids. There are, as part of the approval process, they had to do some what's called post-marketing studies after the drug has been in the marketplace. There are some studies ongoing right now. Many of you may be aware of it, that they're doing at different hospitals around the country, comparing SMOF to Intralipid in pediatric patients, and they're looking at different outcomes. The one thing I can say is SMOF is not suitable for that lipid-restricted dosing that we've seen with Intralipid. Some people, when we started seeing that lipid emulsions might be bad for the liver, we started reducing the dose. However, you can't do that with SMOF, because SMOF already has less soybean oil in it. When you think about it, a gram per kilo per day of Intralipids equivalent to around 3 grams per kilo per day of SMOF. So you want to use SMOF the way the manufacturer wants you to, as opposed to the way we do things off-label, like with Intralipid doing the low-dose approach. It's not suitable for lipid restriction. So what's still investigational? Omegaven is still investigational. When I came here back at the Cape, back around over 10 years ago, when we first talked about this, we thought we were going to have it approved by now, but it still isn't. It's approved in Europe. It's a pure fish oil emulsion. It was marketed to be mixed with Intralipid. The dose that the manufacturer came up with was 0.2 grams per kilo per day. When we use it to treat liver disease in children, we do 1 gram per kilo per day, and we do not mix it with Intralipid. There's no pediatric indication for either in Europe or, and it's not to be designed to be used as monotherapy. And we do it totally off-label this way under a compassionate use protocol. Still not FDA approved, although things are moving slowly. The data is being collected to be submitted. We first used this in 2002 to treat a patient who was totally allergic to soy. And when this is the only soy-free lipid emulsion anywhere in the world. It's still the only soy-free lipid emulsion anywhere in the world. He had essential fatty acid deficiency. It treated the essential fatty acid deficiency. So again, it was a proof of concept. We knew we could use it as monotherapy and not get patients deficient. We subsequently used it to treat liver disease in children. We've published it in Pediatrics. We stop all, in our protocol, and it's like I said, it's a compassionate use protocol. You have to have pre-existing liver disease. You can't use it to prevent liver disease currently, the way the FDA has our protocols approved. So you stop the soybean oil, you switch to Omegaven at 1 gram per kilo per day. For the rest of the time, you're on parenteral nutrition, and you make up for those loss of fat calories as carbohydrate. And if you ask me why we haven't used SMOF to treat pre-existing liver disease with the SMOF instead of Omegaven, which is approved, SMOF being approved, we always go back to our animal studies. This slide just shows you graphically. This is a chow-fed mouse. That's our reference standard. And we always compare the livers of the mice to a normal chow-fed mouse. Omegaven and chow are very similar. When we switch to the other lipid sources, such as Intralipid, that's the worst. All that red is bad. Clinolipid also equally as bad. That's why we never jumped to Clinolipid when people offered it to us. And when they were offered SMOF, it's kind of an in-between. If you have pre-existing liver disease, we wouldn't want to treat with that. You might want to use it to prevent or use it at a patient population at risk, but if you already have PN liver injury, because of this data we have in animals and as well as case reports from Asia, we probably wouldn't recommend using a SMOF blend to treat pre-existing liver disease. But again, this is all off-label. So in summary, the products that were approved are only approved for adults. No matter what you may think of my biases, I still don't think we have a perfect lipid emulsion. I could tell you flaws about all the products if you wanted me to. We've made progress. Like I said, we've had 2 different products approved in the U.S. in this millennium, but we still have a long way to go. And of course, I can't do this alone. We have the lab with Mark Puta's lab, and we also have the care center. They have a table out there if you want to say hi to them. There's a bunch of our team members here, but it takes a village to treat all these patients. And without all of them, we'd not be making any progress. So thank you.
Okay, I'm going to get tough. We can take 2 questions make them good, and then we're going to defer everyone to the breakout session this afternoon. Oh, pick your favorites, Bob.
So people with pre-existing allergies such as fish, seafood, would they be, what kind of lipids would you recommend for them specifically?
Okay, well, that's going to be a challenge. I don't want to know what the nature of the allergy was, and that's why you talk to an allergist, because it's, sometimes allergies aren't allergies. It might be an intolerance. So you'd want to get a real, an allergist involved for the, if it was truly an anaphylactic reaction. Like my soy allergy patient, we tested him with Intralipid, he anaphylaxed. He would have died if we continued onward with him. So they'd have to evaluate that. You'd be stuck with soy if you truly were anaphylactic. Okay. You'd have to, again, I would never do this you'd get an allergist involved.
Kathy, one thing that's not really a question, but a comment, because neither of us, you're not old enough to remember this. I probably am, but I wasn't doing this kind of thing then. Was before Intralipid was approved in the United States, what they did was slather
topical oil
okay, on the adults and children. So whoever does the laundry at your house would really probably shudder to hear this, but that's how they got their lipid back then.
Yeah, actually I didn't get into that, but our soy allergy patient, we did try that, but he had really bad skin issues back in the day. We still did it with kids who were intolerant to lipid emulsions. Babies and isolators would burn because they'd be coated with oil, and you'd put them under warming lights so you'd fry the baby literally if you weren't paying attention. So not a good idea. So that's another reason why it's good that we have choice now to get different products.